All right, good afternoon and welcome to this live online event from Banner Health focused on providing usable strategies you can start today to keep your brain sharp. I'm Eric Sperling and we are so happy to have Dr. Jeremy Pruzin with us today. He is a dementia specialist with Banner Health. Doctor, thanks for being here.
Happy to be here.
All right, today we will be providing insights into the connection between heart health and your memory and thinking, leaving you with what you can do now to keep your brain healthy as you get older. Now, this specific event has been personalized for the 30 to 40 age group. So before we get started, I want to encourage the audience, though, to take part in Banner Health's Heart Age Test. And you can find the link, Sierra put it right there in the chat. We'll be referencing this test a few times throughout today's event. I think we've got it pinned to the top of the chat there, so a great resource for you to check out. And here's how today is going to go. We will have Dr. Pruzin share a little bit about his background and expertise and also share some critical information about today's topic. We'll then get into some pre-submitted audience questions, and then we'll get to some live questions as they come in. So just use that chat feature to submit your question, and just know we might not get a chance to get to all those questions today. Now, this is a live streaming event, so depending on your internet connection, you might experience some buffering from time to time. Should you lose connection or if the stream goes down at any point, we always recommend just logging off and logging back on. That tends to fix it. All right, let's get into it. Dr. Pruzin, let's talk about your background and why you're so passionate about what you do every day.
Sure. So I'm a neurologist by training, and I specialize in dementia. But I have a specific interest in strategies to implement in midlife that will help reduce one's risk. A lot of them are common sense, but are all backed up by science. So a lot of times I like to say, tongue-in-cheek, my interest is comprehensive dementia care for cognitively unimpaired persons in middle age.
So were you always passionate about this? Was always the direction you wanted to take?
That is the case. I sort of went into medical school thinking about neurology and dementia, contributing to Alzheimer's disease research, and my specific interest in middle age sort of developed as I trained, and I learned more about risk factors and what's going on, pathology in the brain, what we find on autopsy and things of that nature, and think this is a key area to make a big difference in terms of reducing people's risk for future dementia.
And we have a tremendous amount of audience questions already pre-submitted, and so as we're sitting here today, again, feel free to put some questions there into chat, but I do want to start with kind of some of the more common ones that you probably get every day. What's the difference between Alzheimer's and other dementias?
Sure. So this is probably the most common question I get in the clinic. Often it's phrased as, what's the difference between Alzheimer's and dementia? So Alzheimer's disease is the most common cause of dementia, and it's associated with specific findings in the brain. People may have heard of the amyloid and tau proteins that accumulate. And there's specific symptoms, most often memory loss, but others as well. But these can overlap with other causes of dementia. In other causes of dementia, for example, frontal temporal dementia, Lewy body dementia, these dementias are associated with different proteins that are found in the brain on autopsy, and typically different symptoms or a different onset of symptoms, although they can overlap quite frequently. And it's not impossible that a person has more than one pathology or protein aggregation in their brain that's contributing to their dementia. I will mention too that it's very common for cerebral vascular disease or problems with the blood vessels to contribute to any form of dementia, but especially Alzheimer's disease.
So I was following along there, and what's the lineage? Like, it's Alzheimer's first, and then Alzheimer's will develop or progress into some of these dementias? So
this is a bit of a complex topic, but I'll try to boil it down and simplify it. So the way the research world and a lot of people conceptualize Alzheimer's disease now is it's defined by the presence of the amyloid protein in the brain. And it turns out we've learned over research over many years and important advancements such as PET scans is that this protein actually builds up in the brain many years or even decades, 20, 30 years before the onset of symptoms. So you may have this protein in your brain but be completely normal in terms of your cognition and only develop symptoms much later on. So Alzheimer's disease itself is defined by the presence of amyloid in the brain. And then Alzheimer's disease dementia, or a sort of intermediate stage of mild cognitive impairment, is when you start to have memory problems and then eventually functional impairments. So the driving's difficult, the checkbook you can no longer balance. That's what we define as a dementia. But the presence of the disease, or the presence, of the protein amyloid, is how we really define Alzheimer's disease.
And let's talk about sort of the focus of today's event. What's the significant link between heart health and brain health?
Yeah, so I think there's a variety, but I think a easy one to think about and conceptualize is that blood vessels and blood vessel health. So we have heart disease is mainly caused by diseases of the blood vessels that feed the heart. And a similar process happens in the brain. And so when the blood vessels harden, or you don't have to have an actual stroke, but it's really related to the health of blood vessels and blood flow. Mostly. There are other aspects as well that are continuing to be teased out with research, but I think that's a simple way to think about it.
Okay, and this specific event, again, is geared towards 30s and 40s. And so one of the questions, is what's one thing I should do today to prevent Alzheimer's? And is this, a time, I'm in 30s or 40s, to start taking some of this action, whether it's mental or physical?
Yeah, absolutely. So one risk for both that I'll point out that's sort of near and dear to me is high blood pressure. So a lot of people develop high blood pressure in their 30s, and then when you get to your 40s and 50s, it's over 50% of people or so. So making sure you know whether or not you have high blood pressure, and then if you do, to make sure it's well controlled. And that won't cause problems for decades out. So you can continually have high blood pressure, have no symptoms, be totally unaware of it until later in life when you have consequences. So understanding and knowing, do you have high blood pressure, and if you do, to make sure it's treated is one way to both preserve the heart of your health and the heart of your brain. And there's clear evidence that high blood pressure, hypertension in midlife is a risk factor for Alzheimer's disease and Alzheimer's disease dementia. So if you don't address it until you're 65 or 70, or you have symptoms, you're going to get a much lesser degree of benefit than if you address it right when it starts, or even prevent it from starting. So high blood pressure is definitely one thing people can be aware of and treat pretty easily with true and tested medications that have minimal side effects that are completely safe. So being aware of your blood pressure and treating it if needed is one important strategy.
All right, what are some other ones? So high blood pressure.
Yeah, so if people are familiar with risks to the heart, so there's a sort of amalgamation of risk factors that are put together to gauge someone's risk for a 10-year cardiovascular event, so a heart attack or something like that. Those things are smoking, don't smoke. You have to keep an eye on cholesterol, which is related to diet. Your obesity or being overweight is also a risk factor for both, and goes into that sort of score. And diabetes. So, and again, diabetes ties into diet for many people, but keeping an eye on all those different risk factors, which are well known for heart disease, are also going to be good for your brain. And there's very solid, long-standing scientific research to support that.
We just spent some time talking a lot about the heart, and I know people are jumping in and out. This is a live webinar, and so I do want to remind everybody we do have the heart risk test available from Banner Health. There is a link for that in the chat. It can really help you out understand what some of those risks might be. It's a great tool, and again, it is available there in the live chat. We'll be referencing it again throughout today's event. Okay, another question that came in. Should we be genetic testing if we have a family background of Alzheimer's?
I think the simple answer is no, unless you have, about half of your relatives on one side of the family tend to develop the disease at an early age.
Okay.
There are certainly risk factors that are genetic that are not as strong, but there are very rare forms, about 1% of total cases, where there's a genetic mutation that is precisely responsible for causing an early onset dementia. So if somebody has a family history of multiple relatives developing Alzheimer's disease before the age of 60, then you might want to consider getting genetic tested or getting a genetic test or first seeking counseling to understand what the implications would be and whether or not that would be right for you. But for a large majority of people, no, it's not recommended. And I don't do it in the clinic, and I wouldn't do it for somebody who came in and wanted to know about their risk. Now that said, people on this webinar, I'm sure there's some that have done 23andMe, and they know that the ApoE gene is on there, which is, other than these more rare forms, that is does put somebody at increased risk for Alzheimer's disease. That said, it's not a guarantee, and I don't think it would change anything necessarily. I would recommend all the things we're going to recommend anyways, whether you have a copy of this gene or 2 copies of this gene or not. Now, if it's going to motivate you more, should you have a copy or 2 copies of this gene, or you want to know, then that's one thing, but it's not something we routinely recommend, although it's not unreasonable if somebody really wants to be informed of their risk, as long as they know the implication.
Fantastic. We do have some live questions coming in. This is great. Again, remember that chat feature is available to submit those questions, and I hope I can pronounce some of this stuff right.
Sure,
You just help me. Is there a link between caffeine? Is it the amyloid protein?
Amyloid, yeah.
Amyloid. Is there a link between caffeine and the amyloid protein in the brain?
No known risk between the two specifically. That's an interesting question. So whether or not there's a direct influence there, I don't think so. At least that's not known. That said, caffeine, for whatever reason, does seem to be somewhat beneficial, maybe for cardiovascular health and otherwise. So does it have a direct link with amyloid? The answer is no. Is caffeine seem to be slightly beneficial for overall cardiovascular health? It seems like the evidence is pointing that way, but that sort of research is really difficult because it's really hard to tease apart.
Yeah, and that's, I think, one of the things we were talking about in our pre-interview session, the commonality of you getting that question around caffeine and its effects.
You know, I will take that opportunity, though, to comment on sleep. So make sure don't let caffeine interfere with sleep. So sleep is something we haven't brought up yet, but another one of these factors that poor sleep is bad for your heart. It's a risk for stroke, sleep apnea. All these things are risks for both heart complications and dementia. It does seem that the amyloid protein is cleared from the brain through the spinal fluid during sleep. So if people are getting poor sleep, disrupted sleep, is a thought that one of the mechanisms that causes that to be a risk factor for future dementia is some dysregulation of the sort of influx and efflux of that amyloid protein out of the brain. It's really when a lot of different proteins, including amyloid, are transported out or cleared out, so to speak, while you're sleeping. So sleep is important, and that may be one link. So not necessarily caffeine, but perhaps sleep. So more sleep helps you clear amyloid is the thought.
And I know sleep specialist isn't in your bio, but what is a poor night's sleep? I mean, again, you can talk about how many cups of caffeine or how many cups of coffee. What's a poor night's sleep?
Sure, I'm not a sleep specialist, but I end up talking with my patients about it all the time, and certainly there's a lot of evidence that shows over a lifetime, starting in middle age, people who have poor sleep, less than 6 hours tends to be where you have the highest risk, where people have higher rates of dementia, more amyloid in the brain. And then if you have sleep apnea, your brain's not getting enough oxygen during the night, and that would be sort of chronic damage over a long time. So I'd say less than 6 hours is concerning, and then anything over 6 hours, people vary. So if you get 6.5, 7 hours, but you don't feel fatigued, you feel rested, you're pretty consistent, then I think that's okay. I wouldn't obsess about it. But if you're getting a poor night's sleep, 5 hours one night, 3 hours another night, and then sleep for 11 hours at the end of the month because you crash, that could be a problem, and maybe it's time to seek consultation.
And sorry to stay on the sleep subject.
Sure. No, it's important.
You did say, that you mentioned chronic there, and I think it's okay, right? If things are going to happen in our lives where we may get 2 hours of sleep or not sleep a night, as long as we're not doing it consistently.
Especially if you go to medical school.
Right.
So.
Exactly. So another question that came in, and we were talking before about, high blood pressure, diabetes, some of these other issues. How often should I be getting levels, numbers checked at the doctor? And again, this is specific to the 30s and 40s age group here. Yeah,
so, I recommend people check their blood pressure every once in a while at home. The doctor is generally not the best place to check one's blood pressure. People are nervous. It may not be done sort of in the best way possible. So people can check their own blood pressure relatively simply with a home cuff a couple times a week and have a good idea of what their blood pressure is on average. So they don't need to go to the doctor to do that one necessarily. I think if you're going to annual screening visits or wellness visits, you're going to get something called the hemoglobin A1C test, which monitors for diabetes or prediabetes. You're going to understand your numbers in terms of cholesterol and otherwise. So I would encourage people, if they want to be on top of these things, to do that annual physical with their physician and bring up these, if your cholesterol is not checked or your hemoglobin A1C isn't checked. I think on a yearly interval is certainly plenty. When you're definitely in your 30s, maybe if you're in your 40s, you have some family history, a little bit more higher risk, you may want to talk to your doctor. But I think that year mark for during a physical is a good time to think about these aspects of health.
You're doing a fantastic job answering all of these questions, but I do want to remind our live audience, if you do have a question for Dr. Pruzin, feel free to put it in the chat there. We'll try to get to them as they come in, but also go back to some of the pre-submitted questions that the audience did submit here. And I do have one you just mentioned about family history. So based on family history, here's the question coming in. Based on my family history of heart or memory issues, am I expected to get it too?
Yeah, so I think there's a big dividing line, and a good way to think about this is that the rates of dementia among people who live to their late 80s or in their 90s, you're basically at a coin flip. So it's incredibly common, almost, I don't want to use the word normal, but it's more common than not for somebody, for example, at age 90 to have some degree of cognitive problems or a mild dementia. So when I get concerned about family history, and this is the way I ask patients who come into the clinic as well, is, if mom, dad, aunt, uncle, brother, sister developed a dementia or cognitive problems, how old were they when they did so? If it's in their 80s, then that's much less concerning. It's sort of a kind of more common process. If it's happening prior to 65, that would be considered early onset. That's certainly concerning. And then you have this sort of gray area in between around 70, 75. But certainly before 70 and multiple relatives starts to give me some concern with regard to family history. One parent at the age of 85, not so worried about.
And that seems to be the theme as we're going through the discussion here. When talking about family history, it's what age? And I think you said 60 earlier. For certain things. So,
for the genetic forms, those people unfortunately tend to develop the disease very early on, typically in their 50s, 55. At Banner, we do a lot of work with Kindred in Colombia, in Antioquia, and their average age of onset, for example, for their genetic form of Alzheimer's disease is 48 years old. So that gives you an idea. So technically speaking, what we define early onset versus late onset is age 65. But for these genetic forms that are where if you have the gene, you're guaranteed to get the disease, tend to be much earlier than that. So, but in terms of research and how we define things, early onset is prior to age 65. And late onset is after.
And speaking of onset, we haven't spent a whole lot of time talking about some symptoms here. And at what point do we make the differentiator between, okay, I was just forgetful for a week or two, or I'm 48 years old now and this is happening consistently, I need to see somebody.
It's a hard one. And that's a lot of what my job is, especially within the clinic, is to for people who are maybe in between or there's a question, to really try to understand if this is an abnormal decline or not. So the first thing that I would say is that if you're concerned, get seen, because the way the research is shaping up now, a lot of the drugs under development are very promising, and if those drugs, the recent approval, controversy or not, but if these drugs do work, it looks like the earlier they're used, the better chance you have of getting benefit. So if there's a question, I would encourage people to get evaluated. And I have no problem. Those are fun visits for me where somebody comes in and I say, I don't think you have a problem, or we did X, Y, and Z test and I wasn't very suspicious for a problem, but it appears you don't have one. So congratulations. Let's check in the future if we need to. Those are fine. Nobody's gonna think that you're wasting their time or have issue with that sort of appointment. On the other hand, minimizing symptoms and letting things go for a long time until people have functional deficits makes it harder to perhaps get into a clinical trial or implement other treatments to make a bigger difference. So if you have a question, get seen. Now, to answer your question a little bit more specifically, aging is normal. We don't, everything when we're 50 and 60 doesn't quite function the same way as when we're, 20 or 30. So you may not be quite as good with names. You may have a little bit of attention problems, be a little less able to multitask. And sometimes it's really hard, even for a trained neurologist or other specialist, to understand if this is normal aging or not. Certainly, if there's this middle stage that we call subjective cognitive decline, where we can't even measure on hard testing, neuropsychological memory tests, we can't find a for sure deficit, but people are convinced that there's been a change and that it's abnormal. And these people do tend to, years down the road, go on to develop more issues than people who don't have those complaints. So these people may very well have amyloid in their brain, but don't have significant symptoms yet. There's trials, studies out there now, maybe not so much for the age 30s and 40s, but certainly in the 50 and 60-year-old age group, where prior to onset of symptoms, people have amyloid in their brain. They can get into a trial to see if they can prevent the onset of symptoms. Things that are clear signs of a problem are really having significant word finding difficulty for really common words. You can't think of the word watch or elbow, something like that. Going into a room and forgetting why you did so. I do that all the time now, so I'm hoping that's not an issue. But I get that complaint a lot, and actually that's more of a sign of normal aging, of something that just sort of happens. Now, it's not impossible that you can't do that if you do have a disease process going on, but that's a much less concerning complaint. And a very classic one symptom to look out for is repeating the same thing over and over again, the same question, not retaining new information. And if that's happening on a very consistent bit, like on a daily basis, multiple times a day, that's certainly a red flag that there's probably more than normal aging going on.
Okay, and we had some questions coming in, but I do want to ask you, because you were talking about testing, what does that look like initially?
Yeah, so it depends on the person, depends on where they're at in terms of symptoms, the degree of certainty. I think from my standpoint, and clinicians, we all have sort of set of standards, but we all have our own style or preferences as well. I think if I clearly see there's a problem with quick sort of bedside testing, as we call it, and by the history and what their family's telling me, I'm not going to put somebody through 3 hours of extensive neuropsychological testing to really understand if they have, how profound their deficits are, if I'm already convinced. So it really depends on the patient, and the people that get the most testing are people who come in earlier, where there's ambiguity. That's at that point we may do those 3 hours of really intensive testing, and then now we can look for biomarkers. So we can look for amyloid in the cerebral spinal fluid using a PET scan, and there's blood tests that are almost about ready for prime time. You can actually order them, but it's still sort of in its infancy. So depending on where somebody's at, but understanding cognition, so with a series of tests, and then if we're trying to determine the type of dementia and potentially treat it with a therapy that targets one of those proteins, we would do a test like a PET scan or a cerebral spinal fluid test to look for the presence of amyloid.
Got it. Okay, so let's get back to now some of the live questions that are coming in. And a reminder too for the audience, you're watching this, you have a link. You can always afterwards share the link. It will be available. Share it with friends or family because you've been doing a tremendous job really helping us understand the link here between, heart health and brain health. Some of the questions coming in, here's one regarding tests. What is the next step / test after the written memory test?
Yeah, so a typical appointment, and you can probably Google these and do them yourself if you want. I actually do one of these on my mom every Christmas for her, a little
Merry
present for her.
Christmas.
Yeah. So there's one called the MOCA, which stands for the Montreal Cognitive Assessment. I think that's the better test. It's publicly available, sort of free to distribute. That's the most common screening test.
Okay.
I believe it's the test that former President Trump was referring to when he mentioned he passed his cognitive test, if people are aware of that, way back when. But it's broadly used as a screening tool to understand if there's a problem or not. Now, some people can pass that written test and appear to perform normal, but I still have a suspicion that they have a problem. That by history, the things they tell me, they're very convinced. Maybe they missed a couple points that were a little concerning, but technically they did normal on the test. And that's a situation where, that test takes maybe 5, at most 10 minutes. That's a situation where we'd send to a specialist who does a long battery of 3 hours of really intensive memory, language, executive function, other type of cognitive tests to really understand, based on a person's education, based on what their sort of estimated pre-morbid abilities or their abilities before they ended up in the clinic, to really understand and help us determine whether there's a abnormal decline in memory or thinking or not. So that's sort of the screening test. The other one is the mini mental status exam. Technically that one's copyrighted, but people can Google that and find that. Those are the two most common screening tests. And actually that mini mental status exam has been around for a really long time and is used as a tool to get for entry into clinical trials, a specific score. And then I'll comment too that, so let's say it was unclear if somebody had a problem or not based on one of these screening tests. And then we move on to send them to neuropsychological testing, and the PhD neuropsychologist says, yeah, it looks like there's a problem in memory specifically. Everything else looks pretty good, but when we really drill down, I think this is abnormal. Then we might say, okay, that's what we would call mild cognitive impairment, most likely. That person is still functioning fine in their everyday life. That's the time when we would likely move on to a biomarker test or look for that protein amyloid, either in the cerebral spinal fluid or with a PET scan.
Okay. So the tests are progressive there. Another question coming in, since ADHD has an impact on memory as well, is there a link between ADHD and Alzheimer's or other dementias?
So that's a pretty astute question, and there's an interesting answer to that. So the answer in short form is yes, to a degree. I would say, ADHD is actually, and this is a little bit into the weeds, but there's a difference between attention and memory. So did you pay attention in the first place and try to remember it and then were unable to remember it, or were you twiddling your thumbs and didn't register the question in the first place? So those are two different aspects. That said, developmental problems, ADHD, dyslexia, other learning disabilities are actually a small risk, do slightly increase your risk for Alzheimer's disease and other dementias. I will comment on a sort of specific instance that's quite interesting, I think. So there's a related dementia called primary progressive aphasia. Now, aphasia means difficulty with language. And the proteins that we find in the brain for one of these forms of primary progressive aphasia is exactly the same as Alzheimer's disease. So you have the amyloid plaques and the tau tangles. Now, there's been a strong amount of research that shows, so this is language predominant, doesn't really affect the memory until many years later. People just have trouble producing speech. Dyslexia itself is actually a risk factor for developing this dementia later in life. So if you have dyslexia as a child, it looks like the sort of language center of your brain has this a little bit of a disadvantage throughout life and puts you at a higher risk for this language predominant form of Alzheimer's disease. So interesting topic for sure. And I will make one more comment on this, is that so often, somebody may have seen somebody in the community or a non-specialist, and I sit down and I do my interview with the patient for a whole hour. And one of the things I ask them is, how did you do in school? What kind of student were you? Did you have any learning disabilities? Did you have any need any extra help? Did you repeat any grades? Were you diagnosed with dyslexia? Were you diagnosed with ADHD? Sometimes people just have attention problems that may look like Alzheimer's disease. And people are usually surprised that I'm asking about how they did in grade school, but it does matter for a variety of reasons, but that's one of them.
Got it. Appreciate the questions coming in. Let's get to a few more. Looks like this one's on supplements. So are there any studies indicating cognitive improvement and CBD supplements?
Yeah, so another common question, the answer is there's no evidence at the moment. That's not something that's been studied extensively. There are actually, the cannabidiol receptors are involved in sort of the memory circuit. So theoretically, it's not impossible, and there's some basic research and otherwise going on in this area. That said, I would not recommend people go out and use CBD to treat their memory. There's just no good evidence. There's no clinical trials. This is very much in its infancy, so very unknown. It may end up being harmful, that sort of thing. So, an interesting line of research, but to this point, we don't know, and it's not certainly nothing that I would recommend to my patients at this point.
Sounds like a question you get often. Another one coming in. So as a person with MCI, I'm not familiar with what MCI is.
So that's mild cognitive impairment.
Okay, due to Alzheimer's, what will be available or testing that can show my progress or decline on a semi-annual basis?
Yeah, so something that we do in the clinic for patients who might have mild cognitive impairment is I probably do it more on a yearly basis. It's probably more useful in that sense. But you can repeat that screening test over time. So the MOCA or the MMSE, and that's something we do in the clinic to track people's how they're doing. Typically, again, on a yearly basis. But in the clinic, we do that, and there are more and more, again, I'm talking about a lot of emerging research, so some of this stuff isn't going to be, or a lot of this stuff may not be available, but there's more interest in using, a smartphone. How do you scroll around on your smartphone? How do you interact with your computer? What's your gait speed? So sort of these monitoring technologies to understand if there's changes over time in the way you're living your daily life, the way you interact with devices and other things, the amount of social interaction. There's something that sort of measures how much you're talking to other people. So these are all ways we're trying to develop to track how people are doing over time. But I think most commonly now it would be to repeat those screening tests because you have a baseline, and then at about a yearly interval to understand if people have not changed over a year, changed a little bit, or are doing significantly worse, which we hope is not the case, but sometimes it is. So that's typically what's done to monitor that. But the other thing too that I always stress and it often gets forgotten is how are you doing? How does your family think you're doing? So history, my appointments are always family affairs, spouses, children, whomever, because they're living with the person. I get a brief snapshot. People tell me things, but I don't know. This is my brief moment with them. So getting the perspective of a spouse, have things changed, have not, is always really important as well.
All right, another live question coming in. Okay, is there a connection, here we go with consumption things again, between excessive alcohol consumption and dementia?
That one's a clear yes. So excessive alcohol consumption is associated with an increased risk of dementia. The more you drink, the worse it tends to be. Moderate or very small amounts of drinking, the sort of one glass of wine a day is not an issue or probably not an issue. But if people, heavy drinking is associated with overall rates of dementia. Whether or not that's through amyloid and some of these other proteins is sort of unclear. But excessive drinking is bad for your brain. A lot of these things are common sense, but they end up being backed up by research.
But another common question you probably get, like the coffee one. Am I supposed to drink one glass of red wine a day and that's going to keep me healthy for the rest of my life? There's lots of that going around.
Absolutely.
Okay. What is the current state of research on the possible preventative link between, I believe that says preventative link, between dementia and fasting?
So another interesting question, again, an emerging area of research. So A lot of people are doing intermittent fasting these days, and so there's some hypothetical advantages, but nobody's done a clinical trial. Although people are proposing this to say, let's look at people who, or implement intermittent fasting in one group and let the other group go on with their normal way of eating, not doing intermittent fasting, and see if it reduces people's risk. Now, intermittent fasting seems to be good in terms of insulin resistance, or not developing insulin resistance, which is another way to say diabetes, essentially. And so if there's certainly a link between diabetes and dementia. It's about a twofold risk. If you have diabetes, your chances of developing Alzheimer's disease goes up by, it doubles. So is there a hypothetical link between intermittent fasting, changing the way your metabolism works, lowering your degree of insulin resistance, and through that lowering or minimizing risk for Alzheimer's disease? Certainly possible, but not proven at this point.
Okay, we've been talking a lot today about the heart risk test that we have, and it's available in the chat, and we can kind of show you what that looks like. And here's a question specific to that. My heart age test shows that I am older than my current age. What can I do to get back on track?
So one thing is any of those risk factors that you may have, so high blood pressure, diabetes, cholesterol, poor diet, any of those things that are not well addressed, poor sleep, we're all human, nobody can make 10 changes at once and hope to hang on to that, but try to address one or two of those issues at a time, or the ones that may be the most harmful, and reduce your risk. The other thing that we haven't brought up yet at this point in the session is physical activity or exercise. So there's clear evidence that in older adults and throughout life that people who exercise, who are physically active, are more resistant to the pathologies in the brain. So for a given amount of amyloid or tau, if one person is very physically active and exercises and another person is not, the less active person is more likely to develop symptoms. And that's something else too, through a variety of ways can be beneficial. Now, none of these things are magic bullets. If you exercise, I'm not going to guarantee that you'll never get dementia, and you don't have to be a marathon runner, so to speak, to provide yourself some benefit. But if we're talking about reducing risk, improving your heart age, so to speak, walking every day, getting a little bit of exercise, doing something that you can continue to do consistently will be helpful.
So the heart age test is a great action item. If you're watching, another action item potentially here is a question coming in. Let's say I'm only 45 and I don't have a family history of Alzheimer's. Can I still help with prevention or research for the next generation? A lot of those out there wanting to help.
Yeah, so yes, and stay tuned. So there's a lot of studies that are what we call observational, where we would follow people over time. 45 is a little bit on the younger side, but more and more that's going to be a potential to participate in research. But there are certainly for people 50 and up, and actually, we've recently trying to decrease the age of one of the studies we do at Banner down to 45, because this is really a disease that developed over the course of decades that starts not just at middle age, but probably, the process starts, it's a lifespan disease. So, from birth to death, where you encounter different risks and you can try to minimize those. And there's more and more study trying to get at that. So there are observational studies where we follow people, we do some tests, you do some imaging, you get maybe an MRI a couple of years, try to understand, are you developing that protein amyloid in your brain, or what sort of things have changed that may predict somebody's risk for developing a dementia later on.
Well, you've been so helpful all afternoon for us as we close out. Is there anything you'd like to wrap with? Anything maybe we didn't cover that you think is an important point to hit home? Sure.
So I think there's one thing we haven't brought up yet, and that is, interesting enough, one of these other modifiable risk factors is social interaction. So being with friends, being with family, And people often ask me, what's good cognitive exercise? Should I take these brain game tests or this and that? Unclear on whether that's helpful or not, but it is clear that having friends, having a network, being with other people is good for your brain. So a lot of my older patients, they like to play bridge, as I encourage them to do that. Sometimes I get in trouble because I may encourage somebody to get a dog and their spouse may not like them, but that will get somebody walking every day. It'll get somebody in the dog park, interacting with other people. So, you know, it turns out we're social beings, and it's good for people. Everybody's a little bit different, how outgoing, this and that, but certainly isolation and loneliness are also big risk factors for developing a dementia later on. And the longer you can maintain a solid social network, the better your family is, the bigger your family is, the more you're with other people, the better you are, which is, you know, been an unfortunate, you know, with COVID and everything, the way things have been the last couple of years, that's been a really difficult aspect for a lot of people, and especially people who are older or may already have symptoms to sort of navigate. So.
Well, Dr. Pruzin, appreciate all of the information and perspective you shared here today. Just a reminder, the link for that heart risk test is in the chat. And again, if you attended today's webinar, you're watching live right now, you have the ability to share that link out with friends and family. So thank you so much for watching and participating, and we'll see you next time.